questions that we prepared for the panel and that we'll start off by asking. But you all have index cards on your seats. If you would like to write questions out, you're welcome to do that as they occur to you. You're also welcome, when we open the floor up to questions from the audience, to come to the microphone and ask your question yourself. So both of those are available to you. So Jen's going to lead us off with the first question.
Okay, share this. Yeah. Can everybody hear me okay? All right, thanks. I usually don't have trouble projecting, so I'm told. In addition, I'll just add a bit about the format to what Karen said and to her lovely introductions is, Karen and I will rotate asking questions, and we have a primary question, and then we also have, for each panelist, and then we'll have a follow-up question to that primary question that anybody on the panel is welcome to respond to, and we'll proceed like that for all four panelists and have plenty of time, don't worry, for audience questions at the end. So, Cara, we're going to begin with you. So the Northwest University School of Nursing has a required senior level nursing course that involves study abroad. In your experience, why is it important for U.S.-based nurses to have experience with diverse global populations?
First of all, thank you for inviting me here to be a part of the panel. And as I heard some people at the podium speaking, I thought we resonated the references to Jesuit principles. And over at Northwest University on the other side of Lake Washington, we would also be talking about our Christian values. And it's a part of our curriculum to help students understand how those Christian values can be played out in their lives, their careers, and potentially their work abroad. The university where I am has a mission statement, and the School of Nursing has a mission statement, both of which would refer to worldview and helping others. And then we would go back to the scripture. Our school was founded to train pastors and missionaries, and over the years it's had many other majors. But I was looking up Luke chapter 16, verse 15 said, he said to them, go into all the world and preach the good news to all creation. So our mission statements, scripture, they encourage us to go abroad and share what hope and services we can. A practical note in terms of what I see students getting out of international travel, or what we hope that they will get, that we program into the syllabus and the course objectives. One would be that students come away with a new appreciation for what they have in the United States. When you go abroad and you're in nursing, you realize that something as simple as a sink with soap to wash your hands between patients may not be a given. And how does a nurse ensure that infection is not transferred from one patient to the next? And when you come back to the States and there's simply sink and soap in your room as you're taking care of patients, we're hoping that our students will have a new appreciation for that. That's not something you take for granted. Another aspect of taking students abroad is internal to the group that travels. We want the students to travel typically in a group of about 8 with a faculty member. The experience of being gone for a month in unusual circumstances, things that you're dealing with things you're not used to, it puts a strain on the group of students. And I love to watch how they work out issues among themselves. Perhaps being a male faculty member, and typically the students are female, I'm not always in close proximity in the evenings. I have my apartment or room, and they have theirs. What's fun to do is to read their journals about their experiences and see kind of a notation that we were having difficulty figuring out what time to turn out the lights, or whose turn it was to get on the internet, or whatever. But we had a group meeting and we figured that out and worked that out. That to me is ideal for the students away from their typical setting to be able to figure out how to resolve
As a nurse and a midwife, I'd like to respond to another facet that I think is really important for nurses and midwives who work outside of the U.S. is that you gain a true appreciation for your profession and the way in which those professions have been professionalized within the context of the developed world. In the developing world still, you often encounter situations where nursing or midwifery is not necessarily, does not hold a lot of respect. Oftentimes there's not a lot of interdisciplinary collaboration. And for a lot of people, it really is a route out of poverty, and the way in which that impacts the manner in which they relate culturally and societally with the clients that they serve. It really is just, it's fascinating, and it's an eye-opener in terms of, once again, appreciation for what we have here, and ranging from the ability to access a university degree in nursing to having a singular route to care for a patient.
I would just like to add to what Suzanne just said, is that I think it makes the person a better person by being able to travel abroad and experience how nursing is, whether it's nursing or medicine or anthropology, how it's conducted in another culture, so that when you come back, you are, in my opinion, better prepared to serve not only in your field, but also you have to remember that the U.S. population ethnic composition is changing. So we do have a lot more diverse communities. So people that we're dealing with could be coming from far countries that you never even knew existed. So I think it's a plus to be able to really work with diverse populations that can come home and serve even better those who are here.
Yeah, I actually first want to start off by thanking the organizers and commending Rebecca on her tremendous work. I've been fortunate to have a chance to do research with students. Part of the research that I did for my public health degree was actually interviewing medical students, global health students, public health, nursing students that participated in medical volunteer programs working with NGOs or teaching hospitals in Nepal. And I had a chance to interview them when they first arrived, so I had a chance to ask them what they felt like their experience was going to be, and then after they were ready to leave, giving them a chance to reflect a little bit on their experience. One of the things that students routinely will say is that one of the most important skills they realized that they had, and I should preface this by saying I'm not a clinician, but is that listening was by far the most important thing that they were able to do. And not only that, what I was saying, people said that they gained a tremendous sense of these incredibly complex and sophisticated medical systems, plural medical systems that people use. There's often the notion that people just want to use Western allopathic biomedicine. It's not true. In fact, they have incredibly sophisticated and complex syncretic practice, mixing all kinds of therapeutic modalities, including the herbal treatments that Rebecca was talking about, and have a whole range of folk illness etiologies, causation beliefs, and seeing that exists not only in the low-income settings that we go to do good or participate in humanitarian efforts, but also back home. We happen to live in an incredibly diverse, not only in terms of ethnic and racial makeup, but socioeconomic status place here in Seattle. And as the demographics change, not only in Seattle, but in the United States, having a sense of this kind of utilitarian medical pluralism that people really just want what works, but to not have their own beliefs delegitimized in the process is an incredibly empowering realization, and I think a useful tool as a clinician, although again, I'm not one, but routinely people would say, this experience made me a more compassionate and capable practitioner at home, hopefully abroad.
Great, thank you. Well, that leads me to the next question, which is actually directed to you, David. So your work has confronted head-on some of the controversial issues surrounding
Yeah, this is a tough question, and I will preface this also by saying that I came to this in a very personal way as a medical volunteer myself, who went out to participate in running over what are called health camps, kind of these short-term medical clinics that pop up for a day or a week at a time, bringing together surgeons, technicians, nurses, physicians from a dozen different countries to kind of provide medical services to as many people who would show up for a week or so. And I found myself involved in medical work that I had no business doing, as not trained in medicine or public health at the time I went. I found myself taking blood, distributing medicines, antibiotics. I was given this role because I was the only one on this team when we were running these health camps who could speak the Poly. I was viewed as incredibly important, doing that translational work. So they often had me doing the work because I could communicate with healthcare workers, with the care seekers, and translate with the teams who came from different countries. I did this for a few years, and over time, it really started to make me think, kind of reflect a little critically on some of the inherent ethical dilemmas that surround short-term medical work like this. I won't go into, I would say, I'll just say that I do have kind of a list of recommendations that I have synthesized from the research I've been doing now for about 10 years in Nepal, interviewing medical volunteers who, before they go and after they're done, the directors or NGOs that coordinate these programs, healthcare workers that interact with medical volunteers, and the Nepali people who seek out the care. And I've synthesized a set of recommendations. I won't go into them because they're kind of lengthy, but if anyone's interested in reading them, please send me an email, and I'm happy to share them.
I'm sending them to my class.
But a few that I think are really important, and I think that are, I was having this conversation with multiple before. I used to feel like I would tell students to not go. Maybe, not only does global health start at home, and there's plenty of social justice and solidarity work and health work that needs to be done right here in Seattle and in the communities where we're living. But a few kind of take-home lessons, or take-with-you lessons before we go and do this work. One is, this is something we were talking about. I'd be interested in hearing students' opinion after that. This phrase that often gets used to justify these trips, which is it's better than nothing. And I think in some instances this can be true. There are certain instances where short-term medical care, direct service delivery is just an unqualified good. Some of these ways involve doing short-term programs that focus on cataract surgeries, dental camps, uterine prolapse, fistula repairs, stuff of this nature undoubtedly transforms people's lives, no doubt about it. But a lot of the programs often involve just short-term distribution of antibiotics, or people presenting with chronic illness or sickness that stems ultimately from the conditions in which people are living. But people who go to do this kind of short-term work feeling like they had to do something, people walk great distances to present, so they prescribe paracetamol, ibuprofen paracetamol, or vitamins, or iron tablets, saying, well, it's better than nothing, at least they go home with something. But I think that there's some truth in that. But a potentially dangerous social line of that is kind of this conflation with healthcare and health. The idea that the reason people who present to these clinics are sick is not necessarily because they don't have access to medicine. In fact, it's often some of the things that Rebecca was talking about. And I know I don't need to sit here and lecture you all as clinicians. Access to clean water, ample self-determined sources of food, other kind of non-medical variables that are ultimately linked to improved health outcomes, improved education for girls and women. So one of the recommendations I always give to students or people who are thinking about going out to do this work is not to medicalize poverty. This is very difficult, and the contours of this are very, I was joking with some people before, anthropologists always say context specific, to kind of skirt around having to pin down some answer. But I think that that's actually very true. It involves doing some of the need-based research before going to participate in programs, seeing what communities what they're really interested in, and what ways you might be able to improve the situations that are not necessarily medically related, but are linked to improve health status and well-being. And we'll leave it at that, just because I know that there's a lot of other folks who can.
Great, thanks, Well, I hope we'll have opportunity to follow up more on that. So the next question actually, again, this is open to you, David, and to the rest of you on the panel, is to ask whether you can talk about a time when you thought that engagement was particularly successful. That specifically when a nursing or health sciences student went abroad and engaged within their scope of practice in a way that you felt was meaningful, and what were the components that made that useful? And you talked a little bit about specific technical interventions that that groups might do, but I'd love to hear some more specific examples from any or all.
Well, I guess I'll just follow up with a quick story, and then I'll stop talking. I was actually, when I saw this question, I went back to look at some of my field notes and the interviews I conducted with a lot of students. And not surprisingly, I found that the nursing students always kind of had their pulse on what was going on, perhaps because nursing is inherently involved in the care work, which is a little different than physicians and surgeons, technicians, nurses interact with them. And this one nurse who was from Austria who was immediately concerned about her presence there from the beginning and was very upfront about it. And she dedicated her time there to not only, she was only there for maybe 6 weeks, maybe 7 weeks, which is not a very long time, but not a 1-week trip. So she had some ample time to try and learn some basic Nepali language skills, which just made a world of difference. Just being able to go and practice and get laughed at and laugh with people and be able to communicate not only with the healthcare workers, but people who were there not expecting this person to be able to engage them in any way in terms of language. But what made this student so unique, I think, was that she understood some of the dilemmas of the ephemeral nature of this care, and that ultimately when she left, the local healthcare workers, the nurses, the auxiliary nurse midwives, the health assistants were going to be there after they left. They're the ones who stayed there. So not only did this nurse go to great lengths to make sure that when she interacted with one of the care providers, she always asked them, and in Nepali, this was one of the very first questions she asked was, how do I say, what do you think about this? Can you teach me about this? And people, Nepali villagers who came, who saw this, were just flabbergasted. You're this expert, this very, knowledgeable person, comes from a much wealthier country. You would be coming here to actually learn from the healthcare workers who I'm thinking don't have the skills all this time. And that deference to local healthcare workers just went miles. It really did, and it was very visible. And they didn't skirt actually giving care. They both together discussed what kind of issue they were confronting. The local healthcare worker who knew the extent problems because they lived in the communities, were familiar with what the burdens were. Together they came up with a solution. It was different. And those were some of the things I think that made it.
Northwestern University takes students to a variety of countries. What we found is that what's allowed in different countries will vary. In India, we go repeatedly. In fact, in each step, we try to build a long-term relationship. The faculty members maintain a long-term relationship. The students are the new faces each year who might reinforce things that students before have done, but the faculty sets the pattern in each country. In India, I was surprised that although you see some very dramatic needs for healthcare, people living on the street, physical deformities that are noticeable at a moment, despite the need that you're confronted with, the regulations on nursing are very strict. And our nursing students are not allowed to do a lot of hands-on care in the hospital there in Calcutta. On the other hand, students go, they have assigned teaching responsibilities at the School of Nursing. So teaching is very acceptable. In complete contrast to what I just said, there was a time when we had a student in the intensive care unit in this hospital in Calcutta, patient coded. The student had learned how to work with code situations in school, but even more so had worked in ICU in America. And the nurses and doctors invited her to help do the antibiotic or something. So with the invitation of the licensed people there, she was able to be involved. Another example, we take students to West Africa. There, we're connected with Mercy Ship. So the Mercy Ship is a floating hospital. The Mercy Ship goes in and does the front work with the country to figure out what can be done with surgeries, when, who can be served. They have all the legalities worked out, and so our students participating in post-operative care, whatever, it's all sanctioned by the local government and the Mercy Ship policies.
I'm not sure that I have a specific story to tell, but I think one of the things that I've seen that impacts students the most is when they are on trips or within student experiences outside of the U.S. and they've been prepared for those experiences, and we'll talk some more about this, I know, but by looking at not only the provision of clinical care, but through a public health lens, obviously, and more importantly, where does healthcare support or healthcare assistance fall within the spectrum of development work? And development work really has a very short history. I mean, it's really only been present in the world in the last 40 to 50 years. And in those 4 to 5 decades that development work has been going on, the science of development is evolving as well, and people have a better understanding of, you know, what development work means, how it's best supported, what are some underlying principles, what is an ethical framework. And I think that when you know, students have that larger picture, it really helps them not be, and this, I don't mean this pejoratively, but not be mired in that clinical experience. And as we all know, students, and understandably so, I was a student, as a student nurse and a student nurse midwife, hunger for clinical experiences, but in some respects I feel like that work really is you know, more than that as well. And one other thing I wanted to say, and I really thought of this, Rebecca, when I heard you talk about your work in Kenya, is that I also feel like healthcare is oftentimes the linchpin for economic development if it's appropriately structured. And a framework is provided for, I mean, it's like beginning tiny baby steps and empowerment when people see that they can collaborate and become partners in healthcare, and they see that there are means by which they can gain mastery over their lives, then I think that's where I've seen the most dramatic transformations in terms of smaller organizations on the ground that work with schools and different programs from the U.S.
Okay, great, thank you. So actually that leads nicely into the next question for Ahwa. We'd like to build on this idea, beginning to hear a theme that Azita introduced at the beginning of partnering system to system, right? Recognizing that all of these things that we're discussing are within a systems framework, and there's a level of complexity involved that is difficult to get to in a short-term sort of way. And so you've worked with health systems strengthening, bringing to your research both your background in public health and in law. So I wonder if you could talk a little bit about how we partner responsibly with those whose legal, healthcare, or education systems might be different from ours, and some ideas you have.
Great. Thank you. Thank you very much. I also want to take a minute to thank both you, Jennifer and Karen, for having us, and thanking Dr. Iman, the Dean, for having us, and Rebecca for the great inspiring story that you shared with us. So it's a joy to be here. Yes, it is difficult working in an environment that may have different, whether legal or social structure than what we have here in the US. But for me, the most important thing is to really work with the people, with the system. I am a product of the public institution. I did almost all my studying in the Ivory Coast in the public setting, and born and raised, and my family. So public institution has been a really strong part in our life. It may not be perfect, but it's there. It's something that we feel like we can always rely on. And fortunately, with economic crisis, the quality of some of the services have gone down, many of the services have gone down, so you may not have quality services. But to me, to really do well in any country, you have to work with the system. You have to work with the people, you have to be able to really listen, like David was saying earlier, to really hear what the people are talking about, what are they struggling with, what are their needs. Only when we work with the people, I feel like we really get to go somewhere that will be really beneficial to all of us. Instead of us going and thinking that we know best and we are going to implant or transplant whatever the way we do things, because we know that that's a faster way, that's a more effective way of doing things. In the Ivory Coast, we started working on this HIV. I started this HIV/AIDS system when I had a traditional wedding there. And a few years after my wedding, I noticed that many of the young girls who were actively involved in my wedding, were dancing and all that in my neighborhood, many of them passed away due to HIV/AIDS. And they had kids and they were being raised by the grandparents. And I felt like, well, we've got to do something about this. So I went to the public health hospital that was there to find out what was happening in terms of HIV/AIDS care and prevention and treatment. And found out there was a standalone clinic that was there that was doing counseling, testing, and providing medication when appropriate. But it was such a standalone clinic that nobody wanted to even walk near it, because just walking across the street from it, you will be labeled as having AIDS or being infected with HIV. So here is the structure that was created to really want to give quality services, but because they really didn't understand the mentality of the people, that it turned out to be a useless and even more, just totally ineffective structure. So it was like, okay, in order to really make it work, we have to integrate it within the system. So we went to the antenatal care to find out what they do with pregnant women in order to really help not only keep the women alive, but also to prevent the prevention from, to do the prevention of transmission from mother to children. And we found out that when the women came to the antenatal care, then they will get volunteer counseling and testing, and if they agree to get tested, they will draw a sample of blood, and then the blood will be taken to a laboratory, and then they'll tell the woman to come back maybe next week to see if the result is available. She may come back on a day that the result has not come to her, has not returned from the laboratory. So they'll say, well, come back next week. Well, if the woman lives in a far place where transport is an issue, so to really, and also family member to take care of. So it was really not practical for them to do that. So we're like, okay, what can we do to really use the system, the existing system, and improve on it? And what we decided was talk to the pharmacy, talk to the laboratory, talk to the nurses, and see how we can make this better. And what they suggested was like, maybe we can serve as, we can use our expertise to also to transport, instead of having the women traveling back and forth to get all those, that the blood get drawn, that we facilitate the transport to the laboratory, and we facilitate the return of the result to the antenatal care, the same place where the woman got her blood drawn and where she's getting her regular antenatal care. And to make sure that the doctor who's connected to really providing the HIV treatment is also there on the day that those women come for their regular visit. So then we got somebody who just come and pick up those blood samples on the motorcycle and take them so really low tech, but that's what people thought was more sustainable. So they will take the plot on the motorcycle, take it to the laboratory, connect it with the laboratory tech, and know when the blood will come back, the result will come back. And then we really put in place a system that turned out to be much more efficient. And so the women didn't have to go back and forth in order to be able to get the care that they needed. So in doing that, working with the system, we were able to really integrate the HIV/AIDS care and treatment within the system instead of having a parallel system. I was really pleased when Rebecca was saying that one of the things they do, that they really work with the local people. I think most of the time, people don't realize that. We just think people are too slow. People don't listen, they don't understand. I know best, I'm going to do my way. So I was really pleased to hear you say that you work with the people, that you really have the local staff running the clinic so that you can really serve in the quality, culturally competent manner. And I think that's very, very, very important. We talk about an aspect that I think many nurses will deal with is female genital cutting or female genital mutilation, which many countries unfortunately continue to do. And often people will say, we'll just go, this is a barbaric, this is a horrible practice, we're just going to go and make it stop. Well, we've put in a lot of money, we put in a lot of tactics, it hasn't really worked. When we do studies, we found out the places that work the best were when people work with the community. They work with the community leader, not just the women, not just the mothers, but also the religious leader, the social leaders, to really come up with a system. It's slow, but whenever they're able to really come up with a system, it's more lasting. So yes, working in those cultures, I think it's very important to be able to listen, to be able to really work with what the people have, and to really see how you can make it better, rather than saying that you have a parallel system that will work best.
Wonderful. So to follow on that, I think that I'm hearing a bit of a public health thread, or perhaps that's just because I'm a public health nurse, but so I think Suzanne mentioned earlier, and certainly I know from talking with one of the professors in Carl's nursing course, what their focus is, and some of the things that Aqua was just saying about involving nurses and other healthcare professionals in this sort of systems changing, right? What are the sort of skills and preparations that we might need to do global work that has an eye towards communities and public health systems and not just towards the medical care? So I know probably many of you have some feedback about